Everybody, and welcome to the first of two discussion sessions as a part of our virtual series here at Cleveland Clinic for Prostate Cancer Awareness Month. Today's topic is prostate cancer treatment options. My name is Andrew Wood, and I'm the Urologic Oncology Clinical Fellow at Cleveland Clinic, and I'll be moderating tonight's session. I'd like to invite all audience members to submit any and all questions via the live chat, and we will try to get to as many as we can, obviously time permitting. So without further ado, I'd like to introduce our three prostate cancer expert panelists. So first, it's Dr. Ziad Schwen. He's a staff member within the Department of Urology. He's fellowship trained in advanced urological and laparoscopic surgery. Dr. Haywood is also a staff member here in the Department of Urology and fellowship trained in by the Society of Urologic Oncology. And then Dr. Oliveras, who is running a little bit late. He's still in the OR and is going to be attempting to join us here a little bit later once we get into things a bit. He's also a staff member of the Department of Urology, fellowship trained in advanced laparoscopy and robotic surgery, and has a special interest in focal therapy. So I'd like to kick off the discussion tonight with some brief words regarding prostate cancer incidence, screening, and diagnosis. So just how common is prostate cancer? So you can see right here in the United States, 1 in 8 men will be diagnosed with prostate cancer in his lifetime. However, if detected and treated early, the 5-year survival rate is nearly 100%, and even beyond 5 years, survival numbers are excellent for prostate cancer if detected early. So what does prostate cancer screening consist of? You may have heard about prostate cancer screening. So what it consists of typically is described as an annual PSA blood test and a physical exam, including a digital rectal examination. So the question of who should get prostate cancer screening. So if you're at average risk of prostate cancer, meaning you don't have a family history or any other risk factors for prostate cancer, you should start screening between 50 and 55 years old. If you're at higher risk of prostate cancer, recommendations are to start screening younger, between 40 and 45 years old. What is a concerning value? Now, of course, this is dependent upon your age, especially in younger men, but our general rule and the guidelines is that a PSA greater than 4 warrants further investigation. If you have any questions about a screening result, it's important to talk to your doctor about the result. And then if you have any questions about wanting to start prostate cancer screening, that's also an important discussion to have with your doctor. So how is prostate cancer typically diagnosed in the United States and abroad? Usually, most commonly, it starts with a positive PSA screen, meaning, again, as we said, a value over 4, which eventually leads to a prostate biopsy with or without an MRI. MRI can be done either before or after the biopsy. These days, we here at Cleveland Clinic are leaning more towards an MRI before the biopsy in order to be able to better localize and target the biopsy to any suspicious lesions from the MRI. Based on the results of the biopsy, a patient will receive a Gleason grade, and that will result in a risk stratification into either low, intermediate, or high risk. So I'm going to kick things off here by asking Dr. Schwen if he'd be willing to just discuss a little bit more about these 3 risk groups that we mentioned, low, intermediate, and high, sort of how we put patients into those groups, what the groups consist of, and then talk a little bit about active surveillance that patients may have heard of and who might be a good candidate for that.
Yeah, this is kind of the most important kind of way to determine who's a good candidate for surveillance, who's a good candidate for treatment, and if so, what treatments you're a good candidate for. And it's really based on our ability to risk stratify people. And the easy way to think about it is into 3 main groups: low risk, intermediate risk, and high risk patients. And these are people who we presume the cancer is still localized to the prostate. So we're talking about early detection here. The low-risk cancer is primarily people who have what we call Gleason 6 or grade group 1. These are people who have cancer that under the microscope after a biopsy have what we think is less aggressive cancer. And this, in general, this cancer does not have the ability to spread outside of the prostate. So that is something that, we know that treatment for people with cancer that is low risk may be over treatment. And that's why we prioritize surveillance and watching this type of cancer and seeing and monitoring it if it is going to potentially turn into a more aggressive cancer. that could potentially spread outside of the prostate. And that's why we do prioritize, well, here at the Cleveland Clinic, but also in general, in other institutions and in our guidelines, we do prioritize active surveillance for people with Gleason 6 or grade group 1 prostate cancer. But it's not all about the Gleason score or the grade group. There's other things that go into the factors of who is low, intermediate, or high. A lot of it is your PSA, how your MRI looks, other factors that may suggest you could be harboring a more aggressive cancer. But in general, that's a pretty easy statement to make in people who have low risk cancer that surveillance is prioritized. When we get to the intermediate risk, which is the next bump up higher, we know that people with intermediate risk cancer do have the ability for that cancer to spread outside of the prostate and potentially become problematic. Metastatic prostate cancer, is the kind of cancer we're trying to prevent because that's the kind of cancer that can be life-threatening. This all happens kind of in a very slow fashion for the majority of prostate cancers, but early treatment prevents the ability of the cancer to spread. Intermediate risk cancer is generally treated for most people. Now, there's a subset of people with intermediate risk cancer that is what we would call favorable intermediate risk cancer. And that's cancer that's more like low risk cancer or behaves more like low risk cancer. And we can do surveillance for some of those people. But a lot of studies have shown that we're actually not very good at selecting people with intermediate risk cancer who are good candidates for surveillance. There have been studies that suggest between 1/3 and 1/2 of patients who we think are good candidates for who are intermediate risk cancer patients with that we think are good candidates for surveillance, may be harboring more aggressive prostate cancer. So we do think that there are some people with favorable features in the intermediate risk cancer category that may be good surveillance candidates. But when we're talking about treatment, intermediate risk cancer patients, are good candidates for treatment, as well as the high risk categories. And those treatment options are kind of determining about your type of cancer, where it's located, how aggressive this appears, because then we kind of go into the treatment of either a whole gland treatment, where we treat the entire prostate, and that's for the majority of patients. For the most of the time, prostate cancer is what we would call multifocal, meaning it's in multiple different locations. Even if we find it in one spot, it's common for there to be cancer in other parts of the prostate. It's just the way the disease behaves and the way prostate cancer arises. So for the majority of people, we treat the entire prostate. Either when we do surgery, we remove the entire prostate, or if we do radiation therapy, we do radiation to the entire prostate. For a small subset of patients, you may be a candidate for what we would call focal therapy, where we treat just one part of the prostate where the cancer is located. And we generally reserve people who are candidates for focal therapy in the intermediate risk category. We generally do not do focal therapy for people who are in the high risk category because we just know that focal treatments have a higher chance of recurrence, higher chance that the cancer can come back. So that's kind of how the risk stratification is probably the most important thing when we determine what's the best way to handle this prostate cancer. Do we need to treat it at all? Can we just watch it? And if we do recommend treatment, do we recommend a whole gland treatment like surgery or radiation, which has the highest chance of success of a cure? Or do we consider you a candidate for a focal treatment, which is kind of a newer, mindset of how to treat and manage prostate cancer, which we just know that not everyone's a good candidate for focal treatment.
Fantastic. Thanks very much, Ziad. So yeah, I just wanted to echo what Ziad said, that as we discuss the rest of the treatment options in a bit more depth throughout the talk today, it's going to be really important to remember this schema of low, intermediate, and high risk, and essentially all the candidacy for any of the treatments that we'll discuss is dependent upon which of these three categories a patient fits into. One other thing I just wanted to highlight, because I feel as if it's a common question among patients without in the community or in clinic, and as Ziad said, Some patients are candidates for active surveillance, but it's important to remember that that's active surveillance. It's not just doing nothing. So we are, in fact, following a strict protocol in order to surveil this cancer, this low-risk cancer, to ensure that there's no progression. And that involves regular prostate biopsies, plus or minus, oftentimes now added onto with prostate MRI, as well as regular PSA. So it's not doing nothing, it's just watching very carefully. Okay, so for the rest of our planned talk today, and eventually we get to the point where we're able to answer quite a few questions from the audience, we're going to talk about the typical standard and perhaps not as standard therapies for prostate cancer. We've already mentioned active surveillance. So we'll talk a little bit about radical prostatectomy. Dr. Haywood, would you mind speaking a little bit about radical prostatectomy, in particular, what patients can expect after surgery, both immediately and potentially what longer term effects there might be, and then maybe a little bit about what the benefits of minimally invasive surgery for radical prostatectomy might be.
Thanks so much, Andrew. So one of the treatment options, as both Dr. Wood and Schwenn have mentioned, has been the radical prostatectomy. And so what is that? Well, that's removing the prostate, and that's one of the whole gland treatment options that Dr. Schwenn had mentioned. And so that's a surgery that we do very commonly here. And so the things that I tell patients to expect is, in order to do that, we remove the prostate by cutting between the bladder and the prostate, and cutting between the prostate and the urethra, and then reattach the bladder back to the urethra. This is a procedure that takes between 2 to 4 hours in most hands. Patients are, in general, either going home the same day or just staying overnight. There's a short outpatient stay. And then they usually have a catheter in their bladder for about 1 week. And after that catheter comes out, we are removing that and letting patients urinate on their own again. The main kind of risk that we talk about with the prostatectomy is obviously it's a surgery under general anesthesia. So patients go under with a full breathing tube, and so they can have reactions to anesthesia medicines, any sort of medical issue that can happen around the time of surgery. But what patients are often asking about is the risks of sexual function changes or urinary leakage. And that's because the nerves that control the sexual function run right under the prostate or right alongside it, and the sphincter for the urine control is right in front. And so, as surgeons, one of our jobs and what we strive to do is in the appropriate patient, work very carefully to try and save those nerves in that urine sphincter. And while we're not perfect at it, we are definitely improving all the time and doing a good job with that. In terms of the benefits of the minimally invasive surgery, that would be the strong majority of what we do here at the Cleveland Clinic, is the minimally invasive surgery. Most of those are done with the robot. And so there's a couple different ways of doing those robotic surgeries. That said, the benefit that we think of that minimally invasive surgery is that patients have smaller incisions, and so they have decreased pain, a little bit faster recovery, shorter hospital stay. As far as those functional outcomes go, I think a lot of us feel, more comfortable using that robotic approach to try and save, be able to save those nerves that control sexual function and work hard to preserve the urine control. The single port option is one that has come about more recently. The newest version of the robot allows us to just use one port of entry for the robot, as opposed to the more traditional robots may use 5 or 6 small keyhole incisions. The single port just has one small port through which that robot operates. And so reported benefits there is that, it's one incision instead of most, which not surprisingly, patients like. They also, recover, very quickly, and they have, very good functional outcomes. And we have several surgeons here at the Cleveland Clinic that do that single port option.
Okay, thank you very much, Dr. Haywood. So I'll speak briefly about radiation therapy. Um, so, well, just with the caveat that we'll be speaking mostly about surgical treatment options here today, because the individuals here are surgeons. But the two kinds of standard radiation therapy for prostate cancer, and again, this is whole gland therapy for prostate cancer that we're discussing here, are EBRT, which is external beam radiation therapy, and brachytherapy, which are the radiation seeds that you may have heard of. Brachytherapy is exclusively for intermediate risk patients, whereas external beam radiation therapy can be given for both intermediate and high risk patients. If you are in the unfavorable intermediate or high risk category, there is typically the addition of what's called androgen deprivation therapy, which is either 6 months or 2 years of cutting off the production of testosterone by the body in order to make the prostate cancer more susceptible to the radiation, and allow for improved outcomes versus just doing the radiation alone. Now, as I said, the focus of this talk is surgery, but we would be remiss if we didn't mention radiation therapy, as it is one of the standard whole gland options for prostate cancer. And all patients that are being considered for surgery or any therapy at Cleveland Clinic are offered consultation with the radiation oncologists here in order to fully discuss the risks and benefits of radiation therapy, many of which overlap or are the same as surgery. So we already mentioned focal therapy for prostate cancer briefly while Dr. Schwen was discussing risk stratification. And we were going to have Dr. Olivares speak briefly about this, and I think that if he's able to join us in a little bit here, he can also contribute a little bit. But Dr. Schwen, would you be willing to talk a little bit about, as you kind of did before, but what are sort of candidacy, who might be a candidate for active surveillance, or not, excuse me, not for active surveillance, but for focal therapy for prostate cancer?
Yeah, that's a very important question. And the main thing is, why would we want to consider a focal therapy when we know that a whole gland therapy like surgery or radiation has a better chance of curing the prostate cancer? Well, it all comes down to side effects. What are the side effects associated with treatment? And the two main side effects that Dr. Haywood and Dr. Wood have alluded to are how it affects your urine control and how it affects your urinary function, and then also how does it affect your sexual function, primarily your erections. And that's just mainly because of where the prostate is located. Dr. Haywood mentioned about the location of the nerves that supply your erections. And as we get older, men rely a little bit more on their prostates to control their urine. And so how it affects your ability to control that, the urinary function, is affected by whether it's surgery or radiation. We do know that focal therapies, for the most part, because we're treating only part of the prostate, have a lower chance of having, sexual or urinary side effects. Now, who is a candidate? So mainly people with intermediate risk cancer that is localized to one side of the prostate. And that cancer usually has to be not too close to the sphincter muscle and not too close to the urethra, because injury to these two structures can really worsen your outcome and be putting you at high risk of having urinary side effects like incontinence. So we do, at the Cleveland Clinic, we've published on this. We've shown that people who are considering focal therapy, we present these cases because we want to make sure that we're doing focal therapy responsibly and not just saying anyone with a cancer is a candidate for a focal therapy. And that's something that's being done in other parts of the world and country, people who will consider anybody a candidate for focal therapy. But we believe here at the Cleveland Clinic, and that's also what the literature shows, that we have to be very carefully in selecting who's a good candidate for focal therapy. Not everyone's a good candidate, because then we would be potentially under-treating your cancer and potentially dealing with a situation where we would have a cancer recurrence. And we always have the best shot at treating and curing the cancer the first time around. So we want to make sure that we're doing the right thing from the beginning. So really, we present patients at a focal therapy tumor board, which is a group of urologists, radiation oncologists, as well as radiologists who go through the MRI, because I think and most men are having an MRI prior to a biopsy, but people who don't have an MRI yet will generally require an MRI to find out if the cancer is just localized to the correct part of the prostate. And we present the case and we decide, is this person intermediate risk? Are there any higher risk features that would make us concerned that they would be at a high risk of a recurrence? And does the patient have a high chance of success with focal therapy? And we also have to discuss that there is a follow-up plan that is a little bit different from most therapies. Most of the time, it's just following your PSA after a whole gland treatment like surgery or radiation, which gives us a good sense of, is there a recurrence of the cancer? And that's just the blood test. But in focal therapy, because we are leaving part of the prostate untreated, we generally have to do a more rigorous follow-up strategy, which involves a PSA, an MRI every so often to make sure that the treated area stays, showing signs that there's no cancer recurrence in the area. And also every now and then doing a biopsy to make sure there's no cancer that recurred either in the treatment zone or outside of the treatment zone. And so that is something that, focal therapy follow-up is a little bit different. And also how we decide who's a good candidate is a little bit different and a little more rigorous of a selection criteria.
Okay, fantastic. Thanks very much, Ziad. So I see that there's a couple questions within the chat, and we're gonna just make our way through just there's one or two more slides and finish talking about salvage therapy, and then we'll start to answer some of these questions. So I really appreciate everybody submitting the questions. We are getting them, and we're going to get to them shortly. Okay, so some of you may have heard about salvage therapy for prostate cancer, which is basically defined as when treating prostate cancer in the setting when it has returned after an initial local therapy, meaning initially focal therapy or initially radical prostatectomy or initially radiation therapy, and then there's a local or even recurrence elsewhere, and what do those therapies look like? So Dr. Haywood, if you could just maybe talk about when it becomes clear to us that salvage therapy is going to be necessary. How do we determine that's going to be necessary? And what are the different sorts of types of salvage therapy that a patient might need to undergo?
Sure. Yeah, so salvage therapy, as Dr. Wood mentioned, is any type of therapy we do, after the prostate cancer has recurred. So whether it be, treatment after you've had a prostatectomy before or after you've had radiation before, when it becomes necessary is a little bit of a tough question. The easy answer is, when the prostate cancer has recurred. But that said, we take a lot of things into account. One is, after we do the biopsy to confirm that there is a recurrent cancer there, is it an aggressive cancer that we need to treat? For example, some of those Gleason 6 or grade group 1 cancers that we may find on biopsy, we may not need to jump and treat those. We also look at the imaging like an MRI or a PET scan, and then the PSA and sort of the trends in the PSA to decide when it might be necessary to do those salvage treatments. Now, I believe it was Dr. Schwen that mentioned our best chance to get the cancer is with our first line of treatment, and that's definitely true. But we do still have several very effective salvage methods to help take care of men if they do have a recurrence of the treatment. One, like any treatment we mentioned today, we can do them in a salvage setting. So we can do salvage prostatectomy, where after prior radiation or a focal therapy, we can remove the prostate. Can also do salvage radiation treatments. So if the cancer recurs after a prostatectomy, or even after prior other radiation therapy, And then finally, we can also do salvage focal therapy. So Dr. Schwen mentioned the focal therapy procedures, such as HIFU. We can do those to any sort of recurrent prostate cancer. Now, the side effects that we talk about, do change some with salvage treatment. And so, before we enter into any salvage treatment, it's very important to have a long discussion kind of with your provider about, what the side effects are for those treatments and how they may differ from the primary setting. Which leads us into the last point here, the importance of that multidisciplinary team. Many of the cases that we consider here, if they have a recurrence of their prostate cancer, we presented our tumor board. And in that tumor board, we have the urologist, we have radiation oncologists, medical oncologists, pathologists, radiologists, the whole team, to really talk about the pluses and minuses of each treatment for each individual patient that has recurrent prostate cancer. And the benefit of that is that the patients are not just getting one opinion; they're getting all the opinions kind of lumped into one, because there's no one right treatment option for these men, and it's basically finding the right treatment option, at that time for that patient. So we personally think it's very vital to have that multidisciplinary team, and that really helps guide patients the right way.
Fantastic. Thanks, Dr. Haywood. So we're gonna sort of kick off here the beginning of the wider Q&A period, where patients, all of you, will have the opportunity to ask questions about your care. I will say, just as a caveat, that if you have a very specific question about your specific case, we generally won't be able to get to answering extremely specific questions that require review of all of the information. And in that case, the best thing to do is make an appointment with a urologist, with a urologic oncologist here at Cleveland Clinic, and to discuss it in person with an official consultation. But that being said, we're here to answer general questions. All of the ones that I'm seeing in the chat are very appropriate. Just wanted to make that quick point. And then, of course, we'll leave this information up here as well. This is where you can go to get more information once we're done here today, and how to make an appointment. So I'm gonna scroll up here and look at a couple of our first questions. So the first question, and maybe I'll give this to you, Dr. Schwen. The first question was basically, can a pelvic MRI be used for a guided MRI? The patient said he's been ordered for a pelvic MRI, and it's meant for a guided biopsy, but he wants to know whether that essentially, if that is sufficient, and how we maybe talk a little bit about how what a prostate MRI is, and what it is in particular, maybe different from a standard pelvic MRI, and how we go about doing fusion biopsies.
Yeah, that's a great question, and this has been one of the major revolutions in prostate cancer management and detection, as well as diagnosis. Prostate MRIs are not the same as pelvic MRIs. Prostate MRIs are what we call multi-parametric, which means that there are a number of different phases of the MRI that help determine different types of information from the prostate. So it is something that the multi-parametric MRI here. Oh, can you hear me now? Yeah, so the multi-parametric MRI looks at other things like how water diffuses, which is important for determining, if a tissue is a cancer or not. The pelvic MRI, generally speaking, does not provide those additional features, which a radiologist will help determine if some area looks like a cancer, or could it be a benign thing like a prostate BPH nodule.
Ziad, it looks like you're muted.
Not sure how that happened. Anyway, so in short, a pelvic MRI doesn't have the additional phases that a prostate MRI typically has. for detection of a prostate cancer. But technically, a pelvic MRI can pick up tumors in the prostate, but they're just not as good at determining if it's a cancer or a benign tumor. But it can technically be used for a guided biopsy. It just doesn't have as good of a detection or, a scoring system that uses, it's called PIRADS, which is important to determine if something is more likely to be a benign nodule or a prostate tumor that's a potential cancer. So it could be used, but it's just not the best one. A multiparametric MRI is best. Not sure what happened to the connection there, but
Great. Awesome. Thanks, Ziad. So we'll move on to our next question, and I can go ahead and answer this one. So the patient's asking whether it would still benefit him to go ahead with focal therapy rather than doing nothing. He's very concerned with about a high risk of losing his sex life, and he has a Gleason score of 7. And so I'll say that that puts you into the intermediate risk category. A score of Gleason 7, assuming other things like PSA are also within that category. And that means that depending upon where you sit within that risk stratification, you may be a candidate for everything all the way down to active surveillance, maybe a good candidate for focal therapy, maybe a better candidate for a radical prostatectomy. So really the intermediate risk group with the Gleason 7s are the patients where that is the biggest sort of variability in what the best treatment option might be for patients. And without knowing the particulars, it may very well be the case that the best option is active surveillance in order to maintain sexual function, but focal therapy might also be a good option for you as well. So I would say that in your case, it would make the most sense to have an appointment with a urologic oncologist, whether it be here at Cleveland Clinic or elsewhere, to really discuss the nuances of the differences between the different therapies.
yeah, just to add on what Dr. Wood said, and I totally agree with what he's saying. It's important for patients to realize that treatment of prostate cancer doesn't mean you won't have a sex life. It just means that there's a higher chance that you may need additional treatment or may have a period of time where you're either having some issues or, with either erections or other sexual functions. But it is, treatment of prostate cancer does not mean that you are going to have no chance of having erections. And, also from the urinary standpoint, no chance of being able to control your urine. Most men after prostate cancer treatment can have a normal sex life. And it's just a matter of selecting, the correct management strategy, whether it's surveillance or focal therapy. But whole gland treatments do have the ability to preserve your sexual function, and that includes surgery with a radical prostatectomy, especially when we do a nerve-sparing surgery. We do, also realize that if there is a recurrence of the cancer, that's when preserving sexual function becomes more challenging. And that's something where in some cases, it's the best option to manage it appropriately the first time around, because each time that we have to do another treatment after the initial treatment, the chances of preserving your sexual function goes down considerably.
Fantastic. Thanks, Ziad. Appreciate that. I think I'll also send this one to you, quick one, because you perform, of the three of us, the most, single port radical prostatectomy. So the question really is a very simple one. Why not perform all radical prostatectomies through the single port, and what might be sort of some of the differences or advantages and disadvantages from one system versus the other?
Yeah, that's a great question. The single port robotic platform has provided us a lot of flexibility in our ability to perform surgery, particularly in patients who are not good candidates for surgery or are thought to not be good candidates for surgery. People who have prior abdominal surgeries, who may have scar tissue in their abdomens. Well, the single port approach allows us to avoid your abdomen altogether and actually avoid those adhesions that you may experience from prior surgeries, which may make it harder and more challenging to do the surgery and may make it only, radiation as the other option for treatment. So it kind of improves our ability to avoid your abdomen altogether. But it really does mimic the exact same surgery that the multi-port robotic approach does. And really, it's just finding the way that, the urologists you see, which tool they're most comfortable using, because it really, mimics the exact same surgery, just maybe allows you to have slightly less pain and shorter recovery. But it's not, significant enough for us to say, oh, all surgeries have to be one port. There's some disadvantages to the single port, and a lot of it depends on kind of what your ability to, how important a nerve sparing surgery is. I tell patients that while I can do an excellent nerve sparing surgery both ways, I generally can do a better nerve sparing approach with the multi-port robotic arms, and that's just because they're a little bit stronger. So there's some pros and cons to each approach. One way is not the only way, but it is something that it allows us to definitely avoid some very hostile abdomens, is what we call it in the surgery world. People who may have a lot of scar tissue in their abdomen that could be difficult to get through and may make it a higher risk operation.
Great. Thanks very much. Okay, so moving on to our next question here. Let me distill it down. I'll send this one over to you, Dr. Haywood. Essentially, there's a patient here with low risk prostate cancer, but high volume, grade group 1, and had a high risk, but had a high risk decipher score of 0.85. And the patient's just asking if we could briefly explain the decipher and how it kind of changes our risk stratification. Can it make a patient go from low risk to intermediate risk or all the way up to high risk?
Sure. So that's it's a pretty broad question, but I'll try to distill it down into a kind of manageable way and talk about the genomic classifiers. And what those are is a series of tests that are based on your biopsy samples. They're sent to a couple different labs. And what they do is they look at the genes that are turned on or off in the prostate. And by doing so, they were able to distill out what is the biologic behavior destined to be for this cancer. And so, for example, like in the question that was asked, this is a low risk cancer just by the pathology with that grade group 1 or Gleason 6 pathology. But the Decipher test, I believe it was, said that it was a more higher risk result. And so that might suggest to us in our decision making that maybe this is a cancer that is destined to be a little bit more aggressive. And so while it wouldn't be a hard and fast rule that we might tip that more from maybe an active surveillance to a definitive treatment arm or method of treatment, it certainly is something that as a physician we would discuss with the patient and maybe put in the column that might support doing a more definitive therapy. The other way that I describe this to patients is that these tests can help us find what we call wolf in sheep's clothing. Like, does this look like a low risk cancer on pathology, but is it destined to behave more aggressively? There's a couple different commercial tests out there. The Decipher, the Oncotype are common ones that we see. I don't personally order them on everybody because the tests can be very expensive and they don't always not always covered by insurance. However, I do occasionally use them for men in which it would change our decision making. So that might be a situation here like a higher volume grade group 1 or a low volume grade group 2 or intermediate risk cancer that might be a candidate for active surveillance or whole gland or definitive treatment, helping us decide which way we might choose to go with that.
Fantastic, definitely. Completely agree with everything Dr. Haywood said. I wanted to just briefly clarify because I realize that we've mentioned it a few times, but I just wanted to clarify because there can be some confusion about the Gleason score system and the new grade group system. So you may have heard us saying things like Gleason 6, Gleason 7, Gleason 8. You also may hear us be talking about the grade group system. So those are two different nomenclatures for the same pathologic grading system. So it used to be the Gleason score was 2 numbers, and the first number was the most common pattern that the pathologist saw, and the second number was the second most common pattern that the pathologist saw. So strangely enough, the lowest grade was Gleason 3+3 or 6. That was the lowest grade that was considered prostate cancer. And that's still true today. And but then there was also Gleason 7 was broken down into Gleason 3+4, meaning the 3 component was more common, or 4+3, meaning the 4 component was more common. And those actually have been shown to have significantly different long-term outcome profiles. So in order to make it a little bit clearer, rather than just calling both those things Gleason 7, there is now what's called the Gleason grade group system. And just briefly, Gleason in grade group 1, as Dr. Haywood was mentioning, is equivalent to Gleason 6. Gleason grade group 2 is equivalent to Gleason 3+4. Grade group 3 is equivalent to Gleason grade 4+3, and grade group 4 and et cetera more or less matches up. But just so you know, grade group 1 is basically low risk, grade group 2 is essentially favorable intermediate risk, grade group 3 is unfavorable intermediate risk, and grade group 4 or higher is essentially high risk prostate cancer. Just wanted to clarify that in case it was confusing for any of the patients out there. So we have a question here, essentially asking a patient that's already had EBRT, and if the PSA, not that the PSA has started rising, but if it were to start rising again, what kind of follow-up treatment would be suggested? And it sounds like it was localized disease to begin with. And I can just jump in and say probably the most annoying answer of all time, which is that it depends. So it depends on the level of the PSA and how quickly it's rising, because it depends upon whether the trend of the PSA appears to be that it's a local recurrence, or that it appears to be that the prostate cancer may have recurred outside of the prostate gland. And we get information regarding that differentiation based upon how quickly the PSA is rising. Oftentimes a urologist or a radiation oncologist will order a PSMA PET scan to determine if there's a recurrence based on PSA. It appears to be there's a recurrence. Where is that recurrence? If that recurrence is only in the prostate, then it would certainly be a conversation to be had with a urologic oncologist or a radiation oncologist about options, including a salvage radical prostatectomy. Sometimes there can be additional radiation that can be given. It also depends on whether the lymph nodes are involved. So, I apologize. Obviously, it would depend upon the situation, but those are some of the considerations that would be made in the event that there would be a suspected recurrence. Okay, the next question here, and I'll send this over to Dr. Schwen. Just generally, which type of biopsy are we recommending here at Cleveland Clinic, transrectal or transperineal? And then I'll answer the second part of the question. It's if the biopsy is after the MRI, does that minimize the targeted or fusion biopsy? And actually, I'll say it's the opposite. If we don't have an MRI before the biopsy, then we can't do a fusion targeted biopsy. So the MRI must come before the biopsy for us to be able to do a fusion targeted biopsy. So yeah, go ahead.
That's a great question. In general, and Dr. Haywood and I both primarily perform transperineal prostate biopsies, and that's the type of biopsy that I generally recommend, and I believe probably Dr. Haywood as well. And the main reason is because it has reduced dramatically one of the main complications of a prostate biopsy, which is sepsis or an infection in the urinary tract, and some of those can be actually life-threatening. And so the transperineal route is an approach where an ultrasound probe goes into the rectum, but the needle that samples the prostate goes through the skin, which is a much cleaner approach compared to the other type of biopsy, a transrectal biopsy, which is the one that's actually still primarily performed here in the United States, where the needle goes through the rectum into the prostate, which can harbor some bacteria and potentially put bacteria into the prostate that can cause an infection. The other advantage of the transperineal approach is that it has a higher cancer detection rate compared to the transrectal. And because it allows us to sample the top of the prostate, called the anterior prostate, where cancers can sometimes be hiding. Most cancers are in the posterior or periphery of the prostate. And that's why people do a prostate exam by sticking, their finger in the rectum and trying to feel the back of the prostate. That's where most prostate cancers are hiding. However, there are some men, about 20-25% of men, who have an anterior tumor in the prostate hiding at the top, which was difficult to sample in the transrectal approach. We generally recommend an MRI beforehand so we can do a fusion biopsy where we can, in real time, sample a suspicious area that was seen on the MRI by fusing the MRI and the ultrasound. Now, that also, an MRI that's normal by itself doesn't mean that we can avoid a biopsy altogether, because MRIs aren't perfect and they may miss up to 15% of clinically significant prostate cancers. So that is something that we do generally recommend, the transperineal approach, but not everyone's doing them.
Thanks very much, Ziad. Okay, so the next question is again, and Ziad, correct me if I'm wrong on this one. I'm just going to answer this briefly because we've already talked about single port a little bit. The question is essentially, how new is single port? And are there any essentially statistical studies that show differences in success rates with regards to side effects? And I am not aware of any data that shows any difference in terms of incontinence or erectile function between single port versus multi-port. Single port's probably been, commonly being performed for about the last, I would say, 10 to 15 years. There is some data to suggest that the transvesical, meaning single port, meaning going into just directly into the bladder, like Dr. Schwen was mentioning, as it might have earlier continence, meaning you recover control of the urine more quickly. But there's also similar data to a multi-port technique called Retzius sparing that also shows earlier returns to urinary control. So that's a little bit more about the technique rather than the approach. Is that what you would say mostly?
Yeah, I agree. We've done studies here at the Cleveland Clinic showing that there are similar cancer outcomes with single port versus multi-port. It's been around for around 10 years. And some of the early work that was done here at the Cleveland Clinic, by Dr. Kayuk, who's a, world expert in the single port approach. But the single port allows us to sometimes get into really tight spaces and regionalize the surgery because of the single incision. And that allows us to get into areas like the bladder, like Dr. Wood mentioned, that there's some evidence to suggest that when we do a transvesical radical prostatectomy, we may have some earlier continence recovery. And that is because we spare the part of the pelvis that can sometimes be part of the important recovery of the urine control. And that's the Retzius sparing. And that's something that, allows us to remove the prostate without removing some of the pelvic control of the prostate, of the urinary control. So that's something that, I think there's more evidence that we need to gather before we start, making major kind of declarations about one approach versus the other, but we view them as similar to the multi-port outcomes. Mainly the advantage is in the early recovery. In the first, couple days, we know that there's less pain, less time spent in the hospital, more likely that you go home the same day, which patients actually prefer. So that is something that the single port does give us an advantage of.
Great. Thanks so much. So I got a couple questions that are kind of on the same sort of direction. So Dr. Haywood, both these questions are with regards to the side effects for radiation therapy, whole gland radiation therapy versus surgery. One is just a general question, or essentially, are the side effects equal, or are there differences? And then there was also a question here about, does radiation have a risk of starting more cancers, secondary cancers, later on down the line?
Sure. Yeah, happy to address both of these. So the first question about the comparing the side effects percentage-wise between surgery and radiation is a pretty tough one to answer, because unfortunately with prostate cancer treatment, there's no free lunch, and so all the treatments we have will cause some side effects. The difference with surgery and radiation is that the side effects that you get are different. So when patients come asking me about surgery, you know, they're generally talking about, as we've discussed here, kind of problems with sexual function and problems with urinary leakage. The kind of common side effects that you can see with radiation, you know, have to do with irritation of the structures that are next to the prostate. And so most commonly, those are the bladder and the rectum. And so patients get some irritation of those structures. So by the radiation irritating them, you know, they can get some frequency, some urgency of the bladder, of both urine and the bowel movements. They can get some bleeding in the urine and the bowel movements, and so they you know, can have some bother from those. Those tend to get better after treatment, and the data that we look at, you know, says a couple percent, about 3 to 4% of patients maybe might have some long-term urinary or bowel side effects. To the second question about the risk of a second cancer from the radiation, that's a very highly debated topic. You know, a lot of the studies that we've done, you know, have widely varied in their estimate of that risk. What I tell men is that there probably is an increased risk of a secondary cancer from having radiation treatment. However, the risks of that secondary cancer, both without and with radiation, tend to be very small. And so while it probably is slightly higher than you know, than if you had surgery, all the risks are very low. And so I would not make that my deciding factor of one versus the other. But certainly, you know, patients, you know, can consider that in their thought process.
Great. Thanks very much. Okay, so I'll just answer this question from Tom, myself very briefly. Just a question is, he had a biopsy with grade 4 cells were present and grade 3 cells were present, but it was not sufficient for a Gleason score. Would that be considered a low risk or an intermediate risk? Again, you know, most likely, if that's, you know, re-reviewed by another pathologist or re-reviewed here at Cleveland Clinic, which we often do with patients who present with some sort of unknown or unclear pathologic results, this would probably be some category of intermediate risk. But which end of the spectrum of intermediate risk, which, as we've talked about before, is a very variable and broad category, it wouldn't be clear from this information. Okay, so this is a good question. So this is a patient who initially chose active surveillance for low-risk prostate cancer, and on the first follow-up biopsy, I think it sounds like a single core of grade group 2 or 3+4 was found, along with some grade group 1, and it was less than 5% within that core. So the patient's question is, does that core exclude him from being a candidate for ongoing active surveillance, or is it always a trigger for treatment, or are some patients sometimes kept on active surveillance with that sort of risk profile? Dr. Schwen, you mind taking that one?
That's a great question. And in general, as I was kind of mentioning and alluding to before, we're not the greatest at selecting who's a good candidate for surveillance, but that doesn't mean that, you know, there are no people with intermediate risk cancer or 3+4 or Gleason 7, also known as grade group 2. There's a lot of confusing ways of saying this. I understand that it's hard to keep up, but in general, people who have a little bit of intermediate risk cancer, and that cancer is primarily pattern 3 and not pattern 4, are the people who are the best candidates for active surveillance. So that's the favorable intermediate risk. People who have primarily pattern 3. So when you get a biopsy report, it'll usually tell you what is the percentage of the pattern 4. It also will tell you how much of the core is involved, and it'll tell you in a percentage. So if it's a 3+4, but the percentage of the pattern 4 is low, like around 5% or 10%, that means it's pretty closer to the low risk cancer. And then also the volume, which is how much of the core of the biopsy is involved, is also kind of a marker of less aggressive cancer. So if there was just one core that had 5% of the core that was intermediate risk cancer, that tells us that maybe this is just a small amount of intermediate risk cancer that might be more likely a candidate for surveillance. And so we don't only just look at the biopsy, we look at other things like your PSA, we look at your MRI to see if all things are kind of in agreement. So in general, we kind of look at all of them together to decide, is someone lower, closer to the lower risk, cancer who has intermediate risk? Or is there some features or findings that may make us concerned that this could be behaving like a more aggressive cancer? And the biopsy is one of them, and the amount of the core does help us decide that. So we try not to just look at one.
Thanks very much, Ziad. Yeah, that's a very comprehensive answer. I think this is an area that we as a field are still trying to figure out, as Ziad said, the best way to select candidates for active surveillance. But as Ziad said, I don't think that any one thing like the 3+4, one core is enough to ever have anyone definitively trigger a treatment. Okay, and then there's a couple questions here that relate to PSMA or PET scans, and under what circumstances, they would be ordered and what their value is. So Dr. Hay, would you mind talking a little bit about PSMA PET and sort of what the current kind of indications for that are, both in the kind of de novo naive setting and then in the recurrent or salvage setting?
Sure. So the PSMA PET scan is a relatively new scan that we've been able to use here in the past couple of years. And so just to take a step back, a PET scan is a type of scan done in nuclear medicine where there's an injected tracer for something, and then they take pictures of the body looking to see where that tracer is taken up. And so, there can be many different types of PET scans that you might have heard of from doctors or friends or anything. The PSMA PET scan is a newer one out there where we're targeting PSMA, which is a molecule that's within prostate cancer cells. And so the idea is that using these PET scans, we can very accurately know where in the body the cancer is. The specific ways that we've been using a PSMA PET scan here has mostly been in the recurrent setting. So patients who may have had, a rising PSA after prior either surgery, radiation, focal therapy, and we're trying to locate where the source of that PSA is. We'll often use a PSMA PET scan to localize where that the site of disease is. Another really exciting place that we are starting to use it is in patients that may have a high risk cancer on biopsy, but traditional imaging like CAT scans or MRIs, bone scans may not show any spread of cancer outside the prostate. And so by using these PET scans, the idea is that we could more appropriately select who might already have some spread of cancer, or in patients that might have been not candidates for surgery because their PSA was too high or something like that. We could try, by proving that it's all localized to the prostate, those patients may actually be candidates for surgery. So, and in these patients with high risk cancer, it may help us more appropriately select the right treatment for them.
Fantastic. Thanks very much, Dr. Haywood. And I'll just add that PSMA PET is a very exciting new technology, and we're really still investigating all of the possible uses of PSMA PET, and something that we're probably going to the indications for will likely even expand over the coming years. So very exciting new technology. There's a question here regarding a recurrence following a local recurrence following EBRT is salvage prostatectomy contraindicated because of the scarring and fibrosis from the radiation? And I can go ahead and answer that one. We perform salvage prostatectomies after external beam radiation here at Cleveland Clinic regularly. As sort of indicated in the question, the radiation effect on the tissues results in scarring and fibrosis, and the fact that the normal anatomy is a little bit changed in an adverse way, making the surgery more difficult. Because of that, and because the radiation also affects the ability of wound healing, the most important thing to be aware of is that the rates of complications, including erectile dysfunction, which is very high, and urinary incontinence, as well as other complications, are going to be higher than in the de novo setting. And so the answer to the question is no, it's not contraindicated, but it would certainly be, you want to have a very frank and honest conversation with your surgeon, including any of the surgeons here at Cleveland Clinic, regarding the risks and benefits of a salvage prostatectomy. Another question here by Joe, just asking whether if you've been treated somewhere else and you have a recurrence, can you come here to Cleveland Clinic? The answer to that is an unequivocal yes, of course. We see patients here with recurrences all the time. Just taking a second and going through some of your questions, because some of them are actually overlapping from some previous things that we've talked about.
I'm just looking at one. What is the recommended treatment for a patient with T3A Gleason 4+3 PSA 9.5 prostate cancer? And that's kind of where there's not a single obvious answer, but in general, if something is T3A, likely that's determined either by an MRI or possibly by our digital rectal exam where they feel the prostate. But that would suggest that the cancer may be extending outside of the prostate or extending into other things like the seminal vesicle or the bladder. And that would be something that would be probably better treated with a whole gland treatment like surgery or radiation compared to a focal therapy. But in general, surgery or radiation would be both effective treatments for this type of prostate cancer. And it is something that really, which one depends on what your goals are in terms of the recovery and side effect profile, as well as kind of other things like your medical history, which may, help us point you in one direction or the other. What are your urinary symptoms at the baseline? Would we expect them to be worsened significantly with surgery or radiation? And so that's kind of where meeting with a urologist that treats cancer would be the best option to help decide, as well as, talking with a radiation oncologist.
Fantastic. Yeah, that's a great question. Okay, so I see a question here, and again, some of these are retreading territory that we've covered already. So we're trying to just cover as much as we can. Also, there are some of the questions in here that are sort of very specific sort of clinical scenarios. And while we'd love to be able to answer all of those here tonight, I think that's a little bit beyond our ability to answer all those questions. So the best thing to do in that case would be to, make an appointment with a Cleveland Clinic urologic oncologist here, and to have those conversations, in person in a more individualized format. So there's a question here, which I think is a question that a lot of patients have about active surveillance. So I'll pose this to you, Dr. Haywood. The question is regarding grade group 1 or low grade or Gleason score 6 prostate cancer, and whether it eventually gets worse as time goes on, and whether it, so to speak, kind of transforms into something worse. And if it does, then why aren't we treating it with radical prostatectomy or whole gland therapy, versus whether maybe it's just a question of if we find other cancers or higher grade cancers later, maybe it was not a progression, but a new cancer.
Yeah, that's a great question. And often one of the very frequent questions that I get from men considering active surveillance. And in short, it does not, having Gleason 6 cancer or grade group 1 cancer does not mean that things will progress in the future. And what I tell men is that if we were to look into everyone's prostate, we'd find cancer in a lot more men than we find it in, and just many of those will never become clinically apparent. And so there are a lot of men with low risk cancer that we found just because they had an isolated spike in their PSA, or we went looking for it. And so it does not mean that things will continue to progress. I have patients that have been on active surveillance for, 10 years, and we keep a very close eye on it, but have never showed any progression to a different, to a higher grade, or shown any higher stage on imaging. And so, as a short answer, no, it does not mean that things will change in the future. And so, the idea of active surveillance is that we can keep a very close eye on it, knowing that we have the capabilities of determining when things are more aggressive or when they might be a problem, and choosing to treat it at that time. And so the way I saw a couple of questions about timing and such of that. In brief, the way that a lot of us do surveillance is by watching a PSA every 6 months, and then intermittently doing MRIs and repeat biopsies. And so I saw a question or two about the exact schedule, how often we do repeat biopsies. There's no set protocol for that. A lot of that is depending on the PSA trends, any changes in the MRI, sort of patient characteristics. And so it's hard to get one specific way that we do it. But the idea at the end of the day is that we're watching very closely so that we know that we can treat things if anything ever were to look more aggressive on follow-up.
Fantastic. Thanks very much, Dr. Haywood. So I noticed a couple questions in here regarding PSA and PSA elevation, and also a question which I think is related with regards to how the prostate size impacts how we think about prostate risk stratification. And Dr. Schwen, if I could pose this to you, if you could discuss a little bit about PSA fluctuations, other things that could cause a rise in PSA, including like prostate size, and how that might make us think differently about an elevated PSA.
Yeah, we know that the PSA is not the smartest test. It's a good screening test to kind of decide who might be needing further evaluation, but it is something that there's other things that can cause, a PSA to be falsely elevated. The main most common one is just having a large prostate. We know that people with larger prostates produce more PSA, and that is probably one of the more common reasons why a PSA may be falsely elevated. Other things like an infection in the prostate or the urinary tract, recent instrumentation like having a catheter in your bladder recently, or not emptying your bladder completely. These are things that can falsely elevate your PSA. So that's why we kind of use the PSA as a first test to kind of decide who may need to be worked up. And then maybe using other tests, like other blood tests, like the Prostate Health Index or ISO-PSA, which are a little more specific for people with prostate cancer. Also, things like the MRI are very good second line testing to kind of decide who needs a biopsy. But it is something that it's important to realize that, if you have an elevated PSA, there are other reasons why it might be elevated and not cancer, but you should get worked up because, we just need to make sure we're not missing a cancer. But a lot of times just repeating the PSA may be a good enough next line test just to make sure that that wasn't either a false elevation from something else that had happened recently, and just to make sure that we're because in about 20% of the time it'll actually go back down to normal range after the first elevated test. So that's something that the PSA just is a good screening test, but it's not very smart.
Fantastic. Very good. Very nice summary, Dr. Schwen. We'd love to be able to answer, as many of all of the questions that we possibly can, but we've gone over time here already by almost 15 minutes. So, I wanted to thank the panelists for their time and their willingness to talk about all these different answers. I wanted to thank the audience for coming and participating and providing all the questions. I think this is a really, this can be a really confusing topic, prostate cancer, and there's a lot of different moving parts. And so I hope that we were able to provide some value for you all here today. But I can't reiterate enough that the best thing to do for any additional questions that we maybe didn't get to is to make a appointment here, at Cleveland Clinic with one of our prostate cancer experts. And again, this is the number here to make an appointment. You can visit the website here on the screen, or send an email if you have more questions about how to get an appointment. I know there were a lot of questions about how to get an appointment with a prostate cancer specialist at Cleveland Clinic, and these are your 3 ways to do it. And you can have a conversation with the schedulers about, if there's a particular, provider you want. And that's really the best way to go about it from here. So again, thank you very much to everybody. And take care.
Great having everybody. Thanks for joining.
Thanks everyone for coming out, and thanks Andrew for a great job moderating.
Nice work, Andrew.